Great. Well, thank you for that introduction. Yeah, so my name is Taylor Jaroszewski is how I pronounce it. If anyone here is Polish, that's not the correct way to pronounce it, but um, so I'd like to thank you guys for giving me this opportunity to give this presentation. This has been about 2 years of work between me and a lot of other people. So I'm really happy to talk about it. So the name of my talk is Creating a Perioperative Registry in Hawassa, Ethiopia. I have no disclosures. So I think this crowd probably knows this already, but in low-income countries, or what I'll say is LMICs, perform a small percentage of surgeries in the world, around 6 to 8%, and yet some of the poorest countries in the world account for approximately 50% of perioperative mortality. The African Surgical Outcomes Study, which was a multinational study that performed in 25 LMICs in Africa, showed that despite patients being oftentimes younger and even healthier, their outcomes were much worse when compared with high-income countries. And so even though we know that these outcomes are worse, it's hard to really track how to fix these problems. And so in the United States, or in other high-income countries, we use quality improvement. This is kind of my take on the Donabedian model, which utilizes kind of focusing on structure, the process, and the outcomes of a system, and really honing down on each of those to make a difference in a system. And so with a registry, what we're really looking at is the outcomes and how can we affect these to improve morbidity and improve mortality. And again, in high-income countries, we have a number of registries that I'm sure you're familiar with. So the ACS NISQIP, which is very famous, the Dutch Surgical Colorectal Audit, the PQIP. Japan also has their own. There's a number of them around. And while LMICs do have registries, they are quite sparse. And so the aim of this project was to create a surgical registry that was truly tailored to the LMIC setting. So the first step of really any global surgery work is identifying a partner, a local partner who has the context and who's excited about the work like you are. And so at the time, the people I was working with, we had an operating partnership with the University of Hawassa through the ACS OGB, which is now HOPE. And the chief of surgery at the time was Dr. Bilai Malese Abebe. And when we pitched this project to him, he had a huge interest in it. And he really became a champion on the ground the second that we started this project. And his enthusiasm really spilled over to a lot of other members of his department as well. And so once we established this partnership, the next step was to determine what kind of platform we were going to use. So what we ended up using was REDCap. We did kick around a lot of other options, and a lot of them were good. So like Kobo Toolbox is one example that we talked about. Some other things we talked about was actually creating our own app. But at the time, the group that I work with is based in University of Wisconsin-Madison, separate than MCW, and they had easy access to REDCap, and we knew that it had been employed in LMIC settings before. One other big thing about it was that it does not require internet to actually gather data. It does require internet to upload data to the cloud, but it does not require it to actually gather data, which was very important for us at the time. So the next thing we started with was how are we going to pick the variables that we're going to include in the registry? And we wanted a broad set of variables, probably more broad than we needed. But the idea behind it was if we could collect a large set of variables, then minimizing that to kind of tailor it to the setting wouldn't be as hard as if we didn't collect enough variables. So to determine this, we started by having a large stakeholder brainstorm in kind of May of 2021. And we looked at different publications of people who published on registries in LMICs and HICs. We looked at other current registries such as the NISQIP and the PQIP. But most importantly, we asked our partners about the local priorities. What was going to be important for them? What was interesting to their department? What was interesting to their hospital? And even at the national level, what was interesting to the Ministry of Health? And how could we utilize this registry for those purposes? So once we came up with kind of a first set, we went through a 6-month iterative process of constant meetings and just asking for every variable. How are we going to collect it? Who's going to collect it? Where are we going to collect it? When are we going to collect it? And importantly, why are we going to collect it? Is it going to be useful? Is it necessary? And also feasibility was very, very important. Like, was it going to be feasible to collect this data? So once we kind of came up with that, we started a trial period. We had our partners in Hawassa really took the reins on this, and we started to do, like a month trial period and kind of reconnecting and saying, well, how is it going? Is it working? Do we need to make changes, et cetera, and so forth. And I'd really like to set the precedent too for the rest of this talk that I'm going to be coming back to this idea, this kind of this quality improvement cycle of, is it working? How do we improve it? Analyzing it again and doing it again. And for me, that's been very, very, very important for this project and probably one of the biggest themes that I've come across. So back to the registry. So how do we collect it? So we utilize one of the main cogs in our wheel is general practitioners. So in the Ethiopian system, general practitioners are individuals who have graduated medical school. They have done a 1-year internship in general surgery, in our case. And now they're working anywhere from 1 to 3 years as general practitioners for a hospital. So these general practitioners, Dr. Tinbet Asayas, who is kind of the higher one, and then Dr. Barakat, they both are designated for the Department of Surgery. And as part of their designations, they help us collect data. They also do a number of other things, such as give lectures, they help out on the wards, and kind of whatever the department needs of them. So they're fairly stretched and they're used for a lot of things. So when we actually go through the process of collecting data, the first step is obviously patient identification. So the way we do this is we go to the operating room logbook and the elective case schedule for the day, and we'll actually register patients at that point. Then to gather pre-op data, demographics, and operative data, our GPs will go to the wards and actually review the charts and collect all of this data. For post-operative inpatient complications, we originally were having them actually go to the chart room after patients were discharged, but I'll talk about this later. But one modification that we made was now we utilize a complication sheet, which can be seen here, that is filled out by the surgical team at the time of discharge for all patients. And then finally, for 30-day complications, which really turn out to more just be kind of like post-discharge, at least 30-day complications, because it's probably plus or minus maybe 5 to 10 days sometimes. We were using clinic follow-ups as well as phone calls, but we found that phone calls work just about as well, and clinic follow-up rates weren't super high. And so now we primarily just use phone calls, although charts are available if need be. So what do we collect? I'm not going to go through all of this, but if you kind of looked at the colored boxes, you can see the general overview of what we collect. So it's fairly broad. There's about 67 variables total, but it includes preoperative demographics. It includes preoperative clinical information such as laboratory values, comorbidities, operative data, including blood loss and major bleeding, post-operative in-hospital data, so morbidity, mortality, length of stay, and then 30-day follow-up. And then this lower box just shows the different complications that we actually collect. So here's some current baseline characteristics of all the patients that we've collected. So I won't go through this whole table, but to suffice it to say, we've collected over 400 patients thus far. The average age tends to be around 40 years old, and then a good mix of males and females, and elective and emergency cases. We did find that most patients, around 80%, are uninsured. But the more interesting chart here is this graph. So this graph shows on the x-axis time, it's kind of small, but the first thing is the year and then the month. And then, so to look at the first one, it'd be the year 2022, month 5, so it'd be May. And this goes all the way until this month, March of 2024. And I think this chart really tells a great story of this entire project. And about a lot of the fun, but also frustrating and unexpected things that can happen in this type of work. So again, and the y-axis, sorry, is the number of cases that were collected per month. So what I'm going to overlay here is some of the things that affected our case our case captures. And so around the time that this registry started, there was a conflict that was going on in the northern part of the country, that in the Tigray region. And in around November of 2022, Hawassa started getting a number of patient soldiers who were sent down, to the point where a lot of their general surgery ORs were shut down. Um, and on top of it, a lot of the priorities in the hospital were shifted towards taking care of these high number of trauma patients. And so we saw kind of an expected decrease. And this kind of started more in like September, but it really hit a brunt in November. So moving forward, towards the end of January and into February, we actually had lost one of our data collectors to matching and residency. So that was great for him. But we went down from 3 data collectors to 2, which ended up being a huge hurdle for us and really stretching our 2 GPs that we had left fairly thin, leading to a lot of missed data. The end of the pilot study was May 5th, or May of 2023. But as I said, we've continued to go and we have this theme of kind of analyzing what's going on and continuing to make modifications. And I'm going to go into that, but we met a number of times in the span of about 3 months, and we kind of looked at some changes that we want to make. And in August of 2023, we made some of these changes, and we've continued to make changes. But as you can see, we've kind of seen a little bit of a spike and an improvement in the number of cases collected. And then this last data point is this month, so it's not fully filled out yet, but just to show. And so here's just some very high level, very, very superficial data to show. Just for time constraints, I didn't want to dig too deep, but this shows a general overview of the cases that we're collecting. So as you can see, the vast majority of patients are getting some type of laparotomy. And I should mention that any patient can have multiple of these. So the N of these cases will not equal the N of the total number of patients who've seen. You can see most common ones, kind of exploratory laparotomy, cholecystectomy, appendectomy, different types of colectomies as well. The other platform oftentimes tended to be very specific things. So in other publications that I've split those up, but just for this, I didn't want to do that too much. And then here's kind of an overview of the complication rates that we've seen. So the in-hospital complications are shown on the left side. So you can see our SSI rate is about 6.5%. Pneumonia was about 6%. Postoperative sepsis was about 5.5%. And in talking to a lot of our partners, Dr. Belai and everyone, we do think this might be a little bit of an underestimation. But again, this is one project that we'll eventually go into, is kind of digging deeper into these and saying, okay, like let's look at these patients who had SSIs, and then let's look at patients who didn't, and let's continue to evolve this registry and improve data collection. And then here's some post-discharge complications as well. So we found SSI rates were about 7.6%. And then a lot of the other in this were actually just kind of continued symptoms. So patients who continued to have abdominal pain even after operations, et cetera. So I want to kind of talk about some of the quality of the registry, and this goes back to the end of the pilot. So this would be like May of 2023. And the first thing I want to talk about is the capture rate. So when we went back and we looked at like what percentage of patients did we actually capture, we were a little disheartened because we found that we only captured about 50%. But again, we wanted to seek to improve this. So the first thing that we did was I met with the data collectors. I met with the people who are collecting this data. I showed them this and I said, well, what's going on? And in talking to them for a very long time, we found that it was definitely the process. And so I'm going to make a very, very amateur sketch of kind of the geography of the hospital and the compound. So at the time, the ORs even still are being reconstructed. And so the ORs are actually located outside of the hospital. So you have the hospital and then maybe 100 yards, maybe not even, is the ORs. And so what the process was during most of the pilot study was we had the GPs who would go to the ORs, and they'd go to the OR logbook and they'd register the patient. And then they would go to the hospital wards and they would collect the data. And as I mentioned before, GPs do a lot more than just this. They teach classes. They oftentimes will work at private clinics as well. They will also do help on the wards. And so in talking to them, they said, number one, this is not feasible to do all of this to go to the ORs and go to the hospital. They also were very transparent, and they said, there wasn't a lot of accountability because we had it was just kind of the two or the three of us. And so we didn't have a lot of accountability. And also we had nobody to track what we were doing. So sometimes we didn't even know when we were missing work. So with that information, we made some modifications. And so the first thing we did was we kind of modified how we would gather data from the ORs. So the resident housing, not all residents live there, but there is resident housing in the compound. And we had a resident champion who decided to help us. And every day, what he would do is he'd go to the OR and he would take a picture of the OR logbook and then share it with his smartphone. And then he would share it through kind of a chat group with all the GPs. So now the GPs didn't have to go to the OR to collect the data. And then the GPs can look at their smartphone and then collect the data from the wards. The second thing we did is we introduced kind of like a very formal manager, which was me, who actually would also get access to the patients from the OR logbook, and then I would cross-reference with the patients that were collected in the registry every day. And so that allowed us to, now if I saw that there was a patient missing, I could go to the GPs and say, hey, where is this patient? And then we could either know why we were missing patients, or we could go back and catch them because we didn't realize that we were missing them. And so when we did this, we found that our capture rate increased to 70%. So 20% better, but we did this over like a 3-month span, but we still weren't super happy with that. So we dug down to see what were the 30% that we were missing. And we found that there was really two main groups of patients. So patients that went to the ICU oftentimes were missed. And the reason why was because the ICU also was in a separate building that was outside of the hospital. And the ICU was fairly strict with letting the GPs in there to collect the data. They didn't like outside people coming in. They wanted to keep it as clean as they could. The other group of people that we really struggled with were patients that came in on the weekends and patients who had like a 1-day stay. So if they were in and out of the hospital really quick, there was just really no time to collect some of this data in the way that we were doing it. And so since kind of doing that analysis, we've incorporated a couple other residents who've actually shown a lot of interest in being part of the registry to also help us. And we're currently doing kind of a test run of having even more people help out with kind of keeping track of, especially these patients who were in these specific groups, so ICU and the 1-day stays. So the next thing we looked at from a qualitative standpoint was the missingness. Overall, our missingness was actually really good. We had about 5.4%, which is usually I've been told anything below 10% is very, very good. And so we were really happy with that. But we wanted to look at the different types of data and the different phases of care. And when we did that, we saw that our demographics, our preoperative and operative data, we were spot on. I mean, less than 2% missingness, we were great. But when we looked at our postoperative inpatient complications and our 30-day complications or post-discharge, that missingness was higher. The 30-day complications, we actually weren't as disappointed as, but the in-hospital complications we were. 30 days was just a lot because a lot of patients don't come to their follow-up and a lot of patients don't answer their phones. So you're just kind of stuck. But the inpatient we really wanted to fix. And so what we did was we implemented what I've previously mentioned, which was the complication sheet. So again, the sheet is filled out by the surgical residents who are on service for every patient who is discharged. And as you can imagine, this took a lot of help from our partners again. So Dr. Belai was had to really push this as well as kind of our resident champions. And so when we did that, we actually found that our missingness went up a little bit, 20.2%. So then we really had to think about that for a second to try to figure out, well, like, why did our missingness go up? And so we looked at the patients that we missed, and we kind of looked at the whole system. And there was one thing that we gleaned that was really good. And that was that because we could use a complication sheet, the GPs no longer had to go to the chart room to look up data. And they were saying that on average, this saved them anywhere from like 30 to 50 minutes per chart. So that was a huge win for us, increasing efficiency of data collection. And then when we looked at the patients that were missed, we saw that there was really two time periods that patients were missed, whereas all the rest of the time periods in kind of the 3-month span that we initiated this were fine. And so the first was one part of their academic year where you had intern turnover. So in Ethiopia, the and this was affected by COVID on top of this, but the chief residents actually left, and then the interns actually left. So instead of having 5 years, they had 3. And that was a huge period of about almost 2 weeks where no data was collected, but we didn't notice it in time. And the second was there was this 5-day span where they just ran out of paper and everything is being collected on paper. And so this was just a big learning experience for us and just trying to continue to work to have this work. And so what we would like to do and what we're trying to do is have this eventually be formally incorporated into the charts, because currently what they have to do is kind of the sheets are there, but they have to actually remember to grab the sheets, and then kind of have it become a part of their culture is what Dr. Belai would like to have done. But we're still working on that. The last part that I would like to mention is the accuracy. So we went back and audited 10% of our charts, and we found that our accuracy was about 82%. But if anyone who's been to Ethiopia, or even if you haven't, if you know this, they have kind of a different time and date system. And so what we noticed was that some of the times and dates were geared towards the Ethiopian system, whereas what the intention was to kind of have it be the international standard, so that if this registry expanded beyond Ethiopia, it would be able to be standardized. So once we removed the times and dates, we found their accuracy increased to about 90.2%. So we'd like to get that higher than that, and it's things that we're still trying to work on, but that's a little bit of a more challenging one, mostly because we're relying a lot on written, and it's a handwriting. What I've kind of noticed, it's a handwriting problem. So the last thing I wanted to touch on was just some of the other impact that this registry has had with the residents and the faculty in Hawassa that honestly has been kind of the most fun and my favorite part of this entire project. So currently they do M&Ms where they use data from the registry. This has kind of been on and off going, just depending on how updated the registry has been. But we've been able to over the last couple months incorporate this fairly well. And then we've also been able to do a lot of projects with the residents and faculty. And so here's some pictures from COSEXA where we made up, I've heard any number from 12 to 20% of the presentations. I'm not really sure, so I'm just going to say about 15% of all of the presentations, which almost all, except for I think one of them, came from the registry. All of them were presented by residents from Hawassa, none of whom had ever been to an international conference before. And to my knowledge, only one of them had been to kind of like a local conference. So that was an awesome experience to spend that much time with them in this type of setting. We're also anticipating that just from those projects that were presented at COSEXA, we'll have anywhere from 6 to 7 manuscripts that a lot of the residents are currently working on. And even coming back to Hawassa after COSEXA, there's been a huge interest from the residents as well as other faculty to kind of get their hands on some of this data from the registry to do some of their own formal research projects, which I didn't spend a lot of time there before the registry, but to my knowledge, this is a huge change in kind of just the research culture at the university. And I've even had one of my happiest moments was one of the residents, Tamarad, actually came up to me after COSEXA and he said, I've never thought about doing research, but I would like to do research as part of my career going forward. And he said it's all because he's been able to see this whole process play out. So that's really been awesome. And so this is kind of my last slide. So just next steps. So currently, we are still working on improving the registry. I don't think we're ever going to stop until we can get it. Hawassa is working to get an EMR, but I'm not sure when that'll happen, but also we'd like to expand this to other places. So I think continuing to work out the kinks and learning from this experience is priceless. We're actively collecting data to perform a risk adjustment on this registry. I anticipate that to be done in about 4 to 5 months. So this will be one of the first risk adjusted registries that I've been able to find in an LMIC, which is really awesome and a huge testament to our partners in Hawassa. And then we've been working on setting up infrastructure. We're working on purchasing a computer and eventually doing a data transfer because a lot of this data is being housed at UW-Madison. But we've been working with IT for the better part of 10 months now to have the RedCap be fully owned and operated in Hawassa. And then, like I mentioned, we would like to expand to other sites. So I know, ACS, the Hope Hub has a hub in Zambia, here's a picture of us. We did a kind of a QI workshop down there before COSEXA, but also Rwanda or other places in Ethiopia as well. So here's some references and then just my thank you slide. And I'm happy to take any questions or comments or suggestions, recommendations, anything.
Great work, Taylor. Thank you for sharing that. Questions or comments from the group? Question. Looks like Mary has a question. Mary is one of our master students who is also an advisor for JPIGO in Kenya. Go ahead, Mary.
Thank you. And that was a very impressive presentation. Especially, I was very keen on the surgical site infections. Because in Kenya, for my capstone, I'm going to do post-discharge tracking for SSIs, for cesarean section mothers. And I've learned a lot about, mine is not a question, I've learned about creating registries and stakeholder brainstorming. And from your presentation, I got that the SSIs in the facility and in 30 days post-discharge differ. There is a big margin, 7.6 and 5.4. So by the end of the day, I've realized that it is doable, and I will be getting back to you so that I can need more guidance from the team, which was implementing this, because you are cutting across many areas, but I'm going to cut across cesarean section only in 10 facilities. Thank you.
Yeah, that sounds awesome. One thing I didn't mention it just because I could talk about this for probably hours, and so I was trying to cut down time. So when we collect the phone calls, and this is good to know for your project, we won't ask patients, did you have a surgical site infection? But we really we walk them through it. So we say, did you have redness around your wound? Did you have purulence coming, or not purulence, but did you have white discharge coming out of your wound? Did you have to go back to the hospital? Did you have this before you left the hospital? So, because we don't want to collect the same SSI post-discharge as there. So it's generally a long conversation between our GPs and our residents. And we have kind of like a little formal training, and we have like a talking sheet even to really encourage our data collectors that when they're talking to them, to not use medical language as much as possible and really walk them through it. And that's been really the best reason that we've had some success in this was because of that.
That's fantastic. I think I think Mary would be very interested in seeing how she can use that learning to apply in Kenya.
Yeah, that'd be awesome.
Yeah, great opportunity to learn from each other. Fantastic.
And I'd be happy to connect you with our GPs and our residents who make these phone calls. If you want to talk to them, just email me separate or whatever.
Yeah, that's a great idea. And if anybody's interested in getting a hold of Taylor, since all the invites have come from Liz, just email Liz and she can connect you. Great. Other questions, comments?
Yeah, I have a question. Hi, Lee
Yes.
Swenson. I'm a student. We're working on kind of a similar thing right now with Cambodia, when collecting and helping them build a data system to collect laparoscopic cholecystectomies. So it's really cool to see the work that you've done, especially as I've tried to work on it. You're all encompassing and it's incredible. So really great stuff. Question for you, with the people that you have on the ground collecting the data, are you paying them? Is there a salary for them, or how are they incentivized?
So it's a phenomenal question. So when I've given this talk in more of a setting of teaching how to do this, what I really stress is that the first thing we did, and this was before I was even on the project, was to look at the local resources that they had. So to go to your question, we do not pay them extra for what they do. They were a resource that hospital already had. The Department of Surgery gets 2 or 3 general practitioners every year, depending on what's available. They're paid for by the hospital to be used by the department for whatever they see fit. So that was kind of a unique resource, human resource that we had available to us, that not everywhere has. So it's super, super important to just understand what unique resources you have available to you. And then, mostly just, I mean, this all came from our partners. Like it was Dr. Belai who said, well, we have GPs, we can do that. And so really to try to like, us tell, we had some experience in creating registries and telling Dr. Belai, like, this is what we need. Do you have something that can fulfill that role? So truly like that back and forth